Yes, sure.
So, good evening and welcome to all of you. Welcome to the fourth series from the Neolect series. So, Neolect is known for its very different um topics being selected, unique speakers, and for the large crowd that it normally draws. So, always excited to be on Neolect. May I first welcome Bala sir, who is our branch president and national AV member. Welcome, Bala sir. May I also welcome our past national president, Dr. P. Sumaran sir. Also, our new state president, Dr. Riaz, all the senior members who have joined us today on this platform, Dr. Murari sir, and all the other senior members. I would also like to welcome Dr. Linz. He is usually the script writer. He's a director of Neolect. So, welcome, Linz. Welcome to our speaker of the day, Dr. Sridhar Kalyan Sundaram. So, I think most of us would have at some point of time come across his videos because of his strong online presence in neonatology teaching. So, all of those short videos, even the long webinars, are always informative and it's constantly updated. So, it's a very strong online presence that we have all gotten to enjoy. So, welcome, Dr. Sridhar, to Neolect. I welcome all the other members who have logged into this platform from our branch and the neighboring branches. So once again, welcome all of you to Neolect.
Thank you, Sumita. So next will be our presidential address by Dr. Riaz. Over to you, sir. Sir, I take up.
Yes. Kelka. First of all, thank you for the invite, and I think this is one of the first programs after my installation. I'm very happy to be with the Kottayam team. So I was looking at the title of the lecture. So that is over treatment in pediatrics and neonatology, and we all know it is happening everywhere, and it's very important that especially like we have come down in the use of antibiotics over the time. It has occurred only because we had seriously thought of it, and we were able to. Sridhar will be telling us how to frame protocols so that we don't overtreat our children and neonates. And once again, I congratulate Dr. Linz and Dr. Sumita and the Kottayam team for initiating such a lecture series. And I hope this will continue through the next year also while I am the president. So all the best once again. I'm not wasting much time before your academic exercise. Thank you. Thank you also.
Thank you, sir. So, sir, for the keynote address, over to Balandra, sir.
Thank you, Linz. Actually, you got confused. The presidential address by me and the keynote address by. Okay, thank you. So, respected National President Sukumaran sir, our chief guest and speaker today, Sridhar Kalyan Sundaram sir, our office bearers of NNF, Dr. Joseph Patani in his absence because he's busy with his online classes. Secretary Dr. Linz, my secretary Dr. Sumita, and our new office bearers Dr. Riaz, President, Dr. Gobi Mohan, Secretary, and our Binukutan Treasurer, and all seniors and friends across the state and country. So welcome to the Neolect series once again. Before that, happy Diwali to all. Neolect series, the brain behind it's Dr. Linz, and he has started well from March onwards, 3 months he has done. But after that, from June onwards, we had busy every month, the week celebrations, ORS, breastfeeding. In between, we had our genetic conference. So there was a gap of 3-4 months, and Linz has come again with another beautiful topic. That is, as Riaz said, over treatment, which is need of hour. And we had a very good speaker in Dr. Sridhar Kalyan Sundaram. My secretary, Dr. Sumita, has told many things about you, sir. So hopefully we will have a very good session this time. And this election fever is going on. So whoever is there in our Kottayam group, I invite you all for our general body on 5th of this November from 7:30. We'll have an interesting talk by our Secretary, Dr. Sumita. So welcome you all. And before that, I would like to thank our President, Dr. Riaz, the Secretary, Dr. Gobi Mohan, and Dr. Binukutan for inviting for accepting our invitation even at the last hour. Actually, I invited them only half an hour back. This came to my mind only half an hour back because election was everything is mine for the last 1 week. Couldn't. So thank you, Riaz, Gobi, and Binukutan. We'll have another physical meeting at Kottayam in the next year. Hopefully, Linz, Joseph Patel sir and Linz will be continuing next year, and hopefully our secretary will be continuing. We have to see that. So with these words, I conclude my presidential address and thank you. Jai Hind, Jai.
Thank you, Bala sir. So we are actually going ahead for the presentation. Before that, I would like to ask Dr. Sukumaran sir for the inauguration part of the session. And Dr. Sukumaran sir doesn't need any introduction to IAP Kottayam or rather Central IAP. Sir, over to you, sir, for the introduction.
Okay. Beloved State President Dr. Riaz Bala, the person behind this Neolect program, Dr. Linz, Dr. Binukutan, then Krishna Mohan, not Krishna Mohan, Gobi Mohan. All Mohans are there. These 3 Mohans are there, which are very closely connected to me. Krishna Mohan, Vishnu Mohan, and again Krishna Mohan and all these Mohans are there. And my beloved friends, brothers and sisters in the academy, and speaker of the day, Dr. Sridhar Kalyana Sundar. Let me at the outset thank the organizers for giving me this opportunity to be here with you and to participate and inaugurate this lecture series conducted by with NNF Kerala, IAP Kerala, and IAP Kerala. And also very happy that I should congratulate Dr. Linz, Dr. Bala, Dr. Sumita, and Dr. Patani for conducting this regular CME program. And I think this is the 4th one in this series. And I request you to continue this program then next year also. And our speaker is, today's speaker is Dr. Sridhar Kalyan Sundaram. He's an eminent neonatologist. He's working in Dubai now. Yeah, he had a very brilliant academic career. He had his MBBS from Stanley Medical College, then MD from Jibbar Pondicherry and DM from PGI Chandigarh. And at present, he is working in Dubai also. And he is going to talk on over treatment of neonatal and pediatric problems. As you all know, over treatment and under treatment is very common in all pediatric problems and neonatology problems. And what I think is that when you see a problem, you must look at 4 correct things. The most important thing is that you must make a correct diagnosis. So your diagnosis should be correct. Otherwise, you will go wrong. And you will treat with multiple drugs, multiple antibiotics may be there. So correct diagnosis, that is the most important thing. Then correct selection of the drug. You must select the correct drugs. For this, as Riaz said, there should be guidelines for almost all problems, neonatal and pediatric problems. There should be some guidelines for management. Then once you select the drug, you must have the correct dose of the drug. The dose should be correct. In the pediatric and neonatology, you must calculate the dose very well. Then the 4th right thing is that you must, the duration of treatment is very important. Duration of treatment, correct duration of treatment should be there. If we follow this, I think we can avoid most of the over treatment and under treatment. And it is very important to have guidelines for management of pediatric problem. And we have got, NNF has got their own guidelines for all neonatal problems. And IAP has also guidelines for almost all neonatal problems. So with these words, I have great pleasure to declare that the CME program is being inaugurated. And I wish this program all the best. And I think that Linz will continue this program the next year also. Thank you, IAP. Okay,
Thank
Linz.
you. Thank you, sir. Thank you for the inauguration part. So we will go ahead with the topic proper. So I welcome Dr. Sridhar sir for the presentation. And Dr. Sridhar actually, as Suvaran sir told, he did his MD and DM from the Premier Institutes of India. And thereafter he moved ahead to UAE. Now, actually, initially Sridhar sir actually chose a topic sir is actually fond of ventilation and the like hardcore neonatology. So something not that interesting to the pediatric side. So he chose a little bit simpler topic. So he himself chose the topic in this for this session. And so over to you, sir, for the session.
Thank you so much. Good evening, everyone, and thank you for the kind invitation. So it's nice that I'm between two batches. So one batch of office bearers are leaving and the new batch is taking over. So congratulations to the new office bearers, Dr. Riaz and everyone, and Dr. Bala and team. Thank you for this opportunity as well. And thank you, Linz. I mean, it's nice to see another ex-PGI colleague as well. And it's a privilege to be introduced by Dr. Sukumaran as well. Very nice to meet you, sir. Thank you. So I'll start sharing my screen. The topic, obviously, as you all mentioned, is very important one. And it's not very heavy, but it's hopefully going to be useful and we'll have some discussion. I'm aiming for about 40 minutes for the talk and then we'll have discussion as time permits. Can you all see my screen well?
Yes.
Okay. So why I chose this topic is obviously that, I mean, all of us are well-educated pediatricians and neonatologists, and we know the rights and wrongs, but for some reason there is a creep that comes in treatment. And over-treatment comes in, it's not only among the quacks, even among the educated and well-qualified pediatricians, it can happen. So it's just to highlight a few things and what we can do. I mean, Dr. Sukumar and Dr. Bala, Dr. Riaz already mentioned the key outlines of like guidelines and stricter regulation, but what more can we do? Why does it happen? We look into those aspects as well as a few examples of our regular practice. So I joined my post-graduation in 1995 at JIPMER Pondicherry. And when we were working as residents, I mean, we used to see babies coming with meningitis. You do a lumbar puncture, there is pus flowing. And these babies have seizures. And the key thing about all these babies, they look like the babies in these pictures. Very chubby, very good-looking, happy babies, but they have striae on their cheeks. And when we dig deeper, you realize that there is betamethasone drops that were used by either the practicing GPs, even pediatricians. And of course, I mean, not to leave the quacks, I mean, there were no practitioners who were not fully qualified. And nowadays, hopefully, the regulations are stricter, but obviously there are always people who are not qualified who practice, and it's difficult in a big country like India to keep track of them. So this is the betamethasone oral drops called Betnasol. And can we mute the mics, please? So Betnasol drops is obviously a trade name, and these babies were. Can we mute Dr. Parvati's mic, please? Okay. So, I mean, this is a commentary written by my professor, Dr. Mahadevan, and Dr. Adisivam is also a professor. So obviously we have a description of what happens when we use the Betnasol drops and why it is being used. So the pressure on the practitioners to get a quick response, the babies start eating. So can you hear me? Okay. So
Yeah.
no problem. Thank you. So there is pressure on the practitioners to treat and get a quick response. And unfortunately, they start the steroid drops. Maybe they intend to give for 3 days, but the parents start seeing a baby eating well. They think it's a sattu marundu. So in Tamil Nadu or Pondicherry, they call them sattu marundu, and the babies get chubby. And obviously, the main response is on their immune system. These babies become immunocompromised. Some of them come with stroke due to hypertension. So it's unregulated use. Here, there are two things. The practitioner who is starting the treatment doesn't educate the family, and also they're using it for unindicated reasons. For example, a viral infection, bronchiolitis, cold. These are not indications to use steroid. So on my YouTube channel, I have made many videos to cover over treatment, either shorts or even longer videos. So this is one of them, oral steroid. Even in UAE, the use of prednisolone, it started for asthma management, but now they are using it for viral infections, viral Vs as well. So again, if the stress is not there for the parents to stop it within the recommended period, and the pediatrician doesn't recommend it unless it's clearly indicated for asthma episodes, it's going to be over treatment here. And I see many comments on prolonged jaundice needing phenobarbital in the community. And of course, we do a lot of interventions in neonatology on a regulated basis. This is one area where if you have a regimented approach, you're going to overdo things. So individualize your practice. I will discuss that as well. And so many babies with watery stools in a breastfeeding baby who is otherwise thriving. Many parents are told that the baby has lactose intolerance. They go off feeds, change the formula to lactose free, and disrupt the breastfeeding. So it happens quite often as well. And we diagnose urinary tract infection based on a bag urine and give them broad spectrum antibiotics for a longer duration. So this again is not ideal. And the same issue with the loose stool. So stool reducing substances are often done when it is not indicated and we overtreat them. So these are simple examples. You can review these short videos, but we'll be discussing some of them as we go on as well. So the goal of medicine is to support good health, and health is not just the absence of disease, but also the state of mental and physical well-being. I'm not intending to cover our community medicine here, but just to recap. And the aim of any treatment measure is to support us to return to normal or acceptable health standards as far as the disease state is concerned. So when you are diseased, you want to just bring you back to normal and then your body starts recovering. So the treatment aims to return the body towards a normal healthy state. So the ideal way of treating is to support the management, but not treat it to the full. Your body's recovery system should take over. So you don't over-treat to correct the illness. You just help enough. Suppose most of the viral infections, you don't need any treatment, even if you need antibiotics. Nowadays, the practice is, and previously we used to give a long course, but now we try to shorten the course. So the chance of antibiotic resistance is reduced. Dr. Sukumaran mentioned about the physiology and the ranges of normal. So this is very important for us to know, because often all that we need to say is reassure the parents. If we know that this is within the range for that patient, and there are acceptable variations. So for example, the size of the fontanelle, the urine pattern for a baby, the stool pattern, there is a wide stooling pattern for the babies, the feeding pattern is different. So you just review, and with experience, you realize that there is a wide range and you start reassuring the parents, but the new practitioners need to imbibe that from their senior colleagues. So you don't need to treat like if a breastfeeding baby doesn't pass stools for 5 days, you don't need to consider that's constipation, because that's a normal pattern. So we just need to be confident enough to pick up these, and we should also be reassuring enough to the family to tell them that, look, there is no need for treating these. Under treatment is a concern where we either miss or delay the correct diagnosis, or there is resource limitation. So in India, for example, the healthcare may not be accessed on time because of resource limitation. Nowadays, we have a widespread insurance cover for the poor patients as well. So hopefully this will happen less, but delayed response to the, delayed access to the healthcare may be a problem. However, even in India, over-treatment does exist as well as under-treatment. And careful and systematic clinical assessment, regular updating of the knowledge are key. So continuous learning, like in these platforms. So congratulations to the team for taking the effort to bring up and also to put these on your YouTube channel, because it's available for anyone ready to see. So the systematic clinical assessment, the medical students are losing the skill as time goes on. So they're relying more on investigations. The defensive practice starts creeping in. Their knowledge base should improve as well. So this starts from the teachers, the professors like Dr. Sukumaran, who are giving the students the training they need. So we need to replicate what they are doing in our current generation as well. And public health measures are needed in poorer countries to avoid this under-treatment, and also avoid the lack of education leading to over-treatment in the patients. So what do we mean by over-treatment? So over-treatment is where we offer more treatment than it's essential to restore the health of the patient. The American Academy of Family Physicians defines over-treatment as the treatment initiated when there is little or no reliable evidence of clinically meaningful net benefit. So basically, you're doing something that's not needed. Over medicalization is something we see always. I will be coming to some examples, like the way we treat labor and delivery or the way we approach breastfeeding. So that suggests over medicalization. Too much focus on something that should be normal makes the patient worried about it, and it doesn't progress as it should, and you end up in more problems. So over medicalization itself is a form of over treatment. So sometimes we over medicalize because we are worried. Deliveries can take place at home, but it's not safe enough, so we deliver them in the hospital. But in the hospital with adequate facilities, we should be allowing the natural process to go rather than intervening. So often we see a rise in cesarean section because the obstetrician has a set pattern of intervening. If the baby doesn't come out by 5 p.m., they have to do a CS and so on. So there is a very nice article from Singapore, and this pitfalls of over-treatment, and some of the key aspects that I will be presenting is taken from this article as well. So the over-treatment leads to overuse of services. So sometimes the physician is not confident enough, so they may start sending unnecessary investigations, unnecessary X-rays, labs. So you're overusing those, overloading the system. You may also be sending referrals where it is not needed. So a cardiologist or a nephrologist may be seeing a patient which you can manage yourself. And over testing we mentioned. When you do excessive tests, you obviously lead to over diagnosis as well, because many times when we do a liver function or a kidney function, some basic abnormality may come, or even a urine routine. Sometimes it picks up a useful diagnosis, but many times it's something that ends up just doing more tests to make sure it comes back to normal or doesn't worsen. So many times the testing leads to more testing, or you may create more anxiety in the patient because you pick up something that is normal, which wouldn't have mattered if you didn't do the test, but because you have the test in front of you, you want to check for it. Again, there are non-medical everyday problems which are medicalized. So even a mild cold, for example, or a headache, which can be symptomatically managed, the patient comes to the physician, then the physician feels obliged that they need to look for more than just the reassurance. If you are experienced and you're going to be practicing in a very clear way, you would probably just reassure and send, but there is pressure in private practice and you may end up doing more than you need to. There are many new guidelines. For example, the American guidelines that are coming out recently are looking at cutting down the cost of treatment, avoiding over-treatment. The sepsis guideline, the early onset sepsis guideline from AAP is an example. The jaundice guideline as well, which was recently revised, is an example. So these guidelines support you. If you are reducing the level of treatment, you have a guideline to back you up. So it's very important that we look at new guidelines and update ourselves. And that's why it's important to follow the regular updates either in the conferences or in the local groups that your colleagues are disseminating. Obviously, you have a busy routine. It's not always easy to read journals and update, but at least the guideline reviews try to go through that. I mean, the IAP, NNF, they're coming out with regular updates as well. And Dr. Ramesh had done a great job as well, bringing up a guideline book from IAP as well. Inadequate communication or education is very important. So between the professionals as well. So for suppose you're handing over a patient adequately, the treatment may not be exaggerated, but if the next physician is seeing a patient as a new patient, they may end up doing more. And same with the referral hospital, getting a patient from outside, you look at what tests were done, only repeat those that are essential to be repeated. Those you can accept the previous results, just go with them. And of course, we explained the risk of not educating the parent when we discussed betnisol or predo, the steroid doses. I mean, if you don't tell them to stop after a certain number of doses and explain that it is dangerous to give more than what is needed, the side effects of the medicines are not explained, they may continue the treatment unwittingly, or they may think it's symptomatic treatment. One common example for that is many patients think the antibiotic with steroid cream for nappy rash is actually a regular nappy cream. So babies come with steroid side effects, even with topical steroid creams, because they saw a good response to the nappy rash. They think it's a nappy rash cream, and no one actually educated them that it has steroids in it. There are 4 important questions that we can train the patients to ask. So this is called the Choosing Wisely campaign. And the patient can ask the physician, do I really need this test or procedure? What are the risks of having the test or procedure? Are there simpler, safer options? And what happens if I do not do anything? So the last question is very important as well. So if these questions are asked, even if the patient, even if the physician wants to prescribe something more, but they know within themselves that they are probably giving for the defensive sake. If the patient themselves are coming out with this question, the physician can clearly tell them, we have the option to treat, but it is safe enough not to treat, or you can offer less expensive or less intensive options. So if the patients are educated, they may come out with this, but actually, as we'll see later, some of the educated patients read from Google and they actually want more to be done. So that becomes a problem as well. So if we educate the patients to ask these questions, the physician who is over-treating may come down to normalizing the care. If you see any of your colleagues over-treating, this is one way to ask them to tone down. They can introspect themselves as to whether this question can be answered. Our patients may not ask us these questions, but we can ask ourselves before we actually prescribe, will it make a difference if I don't give this treatment? And proper education. I mean, sometimes it's just a matter of asking them to come back after 2 days for a review rather than give an antibiotic at that stage. So educate them that giving the antibiotic is not in your best interest. And if you come for a review and check, or if any worsening, we can consider treating. And these education, communication matters. Is over-treatment a problem? I mean, there is no clear data. It's very difficult to quantify because most of the time, only the doctor who is over-treating may know, or even they may not realize that they're over-treating. And the patients, of course, if they have side effects, they will come to someone else and they may tell them it was not needed, but otherwise they may not know. So potentially 30% of healthcare costs are related to over-treatment, but this is a rough estimate. And there is varying implications in the developing world compared to the developed countries. So in the developed countries, it may be rising insurance cost, for example, from over-treatment. But in the developing world, you're actually going to deprive someone who would benefit from the treatment because the cost for the healthcare is limited. And you're instead of spending it on someone who deserves it more, you're over-treating someone else. The USA has been shown to spend substantially more per person on healthcare. However, the results of the health outcomes like life expectancy or disease-specific mortality rates are not significantly better, and actually they are poorer in some of the more developed countries. There is a significant health disparity within the different populations, the Afro-American population, the Hispanic population compared to white population. The Indian and Chinese patients don't fall in that bracket. They tend to do reasonably well because the socioeconomic strata is better than the Afro-Caribbean or the Hispanic races. So that's a different story altogether. But just because you spend more on healthcare doesn't mean you would have a better outcome. And despite a growing awareness that over-treatment is a problem, it's challenging to measure over-treatment. So it requires defining what appropriate care is in the first place, and this is subjective to an extent. You may have guidelines which tell you, but obviously each guideline caters to a broad group and there are individual patients who are different. So a physician may feel that this patient deserves a treatment that's not in the guideline. And if he documents adequately the justification, maybe it's okay. But if they just prescribe, the other person who is seeing it may not know. So you don't know the justification for over-treatment in that case if you are not documenting. And quantifying benefits and harms is difficult because the evidence is incomplete or poorly documented. And sometimes the harm happens later. Like antibiotic resistance is not something you would see or measure immediately. It's over time. And we are seeing a great epidemic in the developing world with antibiotic resistance. The threshold between appropriate and inappropriate care can vary among patients and patient groups. So what is appropriate for a newborn may not be appropriate for an adult and vice versa. And again, each physician or each patient group has a different value and preference. So how do we say that something is benefit or harm for a particular group? So it's going to be subjective to an extent. So to classify it needs a consensus, which may not happen. There is a lot of subjectiveness in this, and that makes it difficult to measure over treatment. So we mentioned that in the low and middle income countries, over-treatment can exist with unmet healthcare needs. So this becomes an uneven distribution of health resources. This will happen definitely in all countries to varying levels, but in the poorer countries, it's going to be more. For example, there are the richer people who do the full master checkups, while the poorer people don't even have treatment for their day-to-day illnesses. And there are, of course, the alternative branches of medicine. So we have the Ayush and the controversy related to how much they can do. We have seen that some of the doctors who are trained in Ayush field are actually covering the intensive care units, they're not supposed to do that. And they are prescribing exactly the same medicines that you are allowed to prescribe after so many years of training. So this will also lead to overtreatment because they don't have the depth of knowledge to realize that what they are doing is overtreatment. They may learn some names of medicines and indications, but they won't have the nuances and they may not have the communication skills, and they won't understand the evidence base as well. So unless they really train again, it's difficult. And if they restrict themselves to routine problems and educate themselves, maybe they will do a good job. But who is going to educate them? Once they jump into practice, they may start focusing on treating the patient rather than learning. So this is a big challenge as well, especially in the Indian setup. So some of you might have watched the episode from Amir Khan on Satyamev Jayate, Does Healthcare Need Healing? Of course, it was criticized a lot among our colleagues, but there are some facts that come out of it, and not everything he says there are wrong. If you watch it again, you'll understand that he did have some justification for over-treatment and over-investigation. We ourselves know some of our colleagues who fall into the over-treatment bandwagon for various reasons. I mean, once they do it on a regular basis, they lose their confidence in actually holding back on the treatment and monitoring the patient and so on, and they find it easier to do it in a certain way. So it becomes their culture or their habit, and they start believing that what they are doing is right. So it's not that they realize it, and that becomes a cycle which we need to break. And that's why the realization should come from within. And also, when, as we discuss later, the focus on training the people appropriately is very important. So now I'll discuss some examples related to our day-to-day practice. So we have many obstetric practices which impact on neonatal outcome, and I mentioned the over-medicalization of the normal labor process. I know labor is painful, and we have many ladies in the audience as well. And it's not to criticize the management, but epidural analgesia, as we will see in the next slide, has a significantly increased risk of leading to cesarean delivery. And obviously, you are going to slow down or dampen the contractions because she's not feeling the pain. The pain is part of the process that makes a mother contract the whole coordination of the muscles with the uterine contraction and so on. So if the pain is reduced, the labor process may not progress. That's just common sense. And unfortunately, epidural has become a routine, and timing the epidural earlier than a certain stage. So you're supposed to progress to 4 or 5 centimeters dilation before you give the epidural, but the anesthetist availability, the timing, so you may end up giving it before the labor has progressed. And the most common reason for LSES is failure to progress after epidural. So we are creating a problem. The other problem is earlier induction of labor than is ideal. So we see a rising rate of deliveries before 39 weeks. All of us know that 39 weeks and above is appropriate to deliver. Below 39 weeks, baby has a higher morbidity. But we end up doing inductions at 37 or 38 weeks for various reasons. You may be able to justify it, but whether it is really justifiable or you are justifying for the sake of justifying is a different story. So this leads to induction on a non-emergency basis for many mothers, and then they don't progress in labor. You may give them epidural on top of that, and then there is a rising rate of CS. And the other problem is once you get a cesarean once, your next delivery is likely to have a CS as well. So it becomes a pattern of repeated cesarean sections because you had one. Previously, we used to do early cot clamping, and that habit persists, but we need to educate, and most of the guidelines for resuscitation have incorporated. Thankfully, the pediatricians are supporting this, and we need the championing more, and so that the obstetricians buy into it more as well. So this, I'm not going to spend too much time, but this is the cesarean section rates all over the world. So you have an extreme where you cannot afford to do, or you don't have the facility. So this is the only group where the cesarean rate is lower than what the WHO wants it to be. So all the other countries, irrespective of whether it's a developing country or so on, the cesarean rates are increasing year by year. You can see here in 1990, it was like 10 to 15% and up to 20%. But then in the 2010, and now it's even projected to increase more. And it's ridiculously high in some cities. It goes to 50, 60%, which is, and this is all over the world. The pattern is similar. You can see in the developed parts of the world, there is no bottom line because the lack of facility is not going to be a factor in these countries. The poorest countries in Africa have a flat line because they don't have the facilities to do the CS. That happens in rural settings. Now the SNCU like settings are available where hopefully they will be able to deliver near the rural parts as well. And we do see maternal mortality because of lack of facilities, but it's improving overall in Asia. It's not as bad as Africa. But this line doesn't give us any hope. It's opposite side what we said, under treatment. But when you come to the affordable level, always the cesarean rates are higher. And this is what we discussed about, either you induce with oxytocin or you give epidural, the rate of cesarean is higher. The older the mother, the higher the rate as well. And you can see here what a big difference. If you don't give epidural, it's the need for the emergency CS due to a failure to progress or fetal distress is lower. While if you give, it's almost double or even more. And the same with the oxytocin induction. Again, it depends on when you are inducing. If it's a post-term baby, probably they are not going to need CS as much. But again, meconium staining, fetal distress and things may come up. And that's the reason as a mother gets older, if you induce the CS rate is going to be high. So you have to train your team, you have to discuss with the obstetric team. We know that cesarean section has impact on breastfeeding rates. It affects the gut colonization pattern. And this has been shown to have a potential impact on long-term health. So we know that babies born by cesarean in population studies have higher risk of hypertension, diabetes, and so on. We also have a higher chance of early antibiotic exposure through the mother or because the baby has TTN and you end up giving antibiotics in the NICU. So all these are factors which impact the baby long term and also affects the bonding. The breastfeeding, of course, is a lifelong impact as well if it doesn't work well because the mother had CS. So we all know there are multiple reports of preterm and early term births having a poorer outcome compared. So even the IQ level is 5 to 6 points lower. The risk of infection is more. The risk of breastfeeding successfully or the risk of needing treatment for jaundice is higher. So obviously all these have to be considered before you deliver the baby a bit premature. So even if it is 37, 38 weeks, the risk is higher. So try to discourage the obstetrician from inducing or doing an elective section earlier unless it's clearly indicated. And we discussed the importance of delayed cord clamping. So actually it's not something which is optional, it's essential because the oxygenation is happening from the placenta within the womb. The baby is born, the lung opens up and the blood from the placenta has to come back to the oxygenation organ, which is the lung. So it's not the blood which should be outside the baby, it's blood that belongs to the baby that has to come back to the baby. So understand this concept and make sure that the obstetrician understands this as well. And delayed cord clamping is not a choice, it's a necessity. So another sad story is the breastfeeding rates around the world. So there are multiple factors for it. Obviously, modernization of care, over medicalization, focus on breastfeeding being perfect or the mother getting painkillers, cesarean section rates. So you can see, I mean, there is so much effort from the government as well as from the IAP and NNF on breastfeeding, but 46% breastfeeding rates. And most of you would see even in the first month, it drops to 70%. This is around 4 to 6 months of age. And United Kingdom, just 1%. And the United States, 19%. Only the poorer countries have a better breastfeeding rate. And obviously, it's a story of occasional formula feed not affecting the breastfeeding. It's a concept that the parents or the family might have, but it's like the camel in the tent story. The camel wants to put the head alone first, but ultimately it goes into the tent and the shake is pushed out. So that's a story that you can quote to the parents about why they shouldn't give even a small amount of formula, because it disrupts the process of lactation, especially in the first week when the breastfeeding is establishing. If you start giving formula, mother is confused, baby is confused, lactogenesis doesn't progress and you end up failing. So this is a slide which shows the prevalence of delayed lactogenesis is almost proportional to your education level and where you live. So if you are in rural Ghana, it's a natural process. Majority of the mothers continue to breastfeed on their own without much support. There is hardly any delayed or failed lactogenesis. So it comes up to 22%, 35% as you go to the richer states. This is in US. So the same applies to the urban areas versus the rural areas in India, where we have more family support. The parents, as they get more educated, they are more anxious about it. And they are worried about the baby having hypoglycemia. What if my baby doesn't get enough milk? Then they ask the doctor. The doctor doesn't have a guarantee that it won't happen. And they say, you can give if you want. And that upsets this process. Again, the medication, the use of painkillers, the use of analgesia, the use of LSES, all these will impact the breastfeeding as well. So this is something we have to focus on. What we are doing for the well-being of the mother in good intention has actually a negative effect on the mother-baby interaction and feeding, etc. So we have many transient neonatal phenomena. For example, a newborn baby born by vaginal delivery has sticky eyes, watering eyes. It's normal because the head is coming upside down. There is congestion of the face, and both the nasal congestion and the eye congestion after birth or the subconjunctival hemorrhage. These are normal phenomena. Cleaning and massage should be enough. And also in the older babies, tear duct obstruction is fairly common. So you often see pediatricians just giving antibiotic drops, and all the more they do cultures as well. And invariably, the colonized organisms will come back on the culture. So there is no need to do culture for these babies. Ophthalmia neonatum is clear cut. You will see purulent discharge on a repeated basis. If it is a staphylococcal infection as well, you'd see pus coming out frequently. But if you have just a stickiness when the baby opens their eyes after sleep and it's little watering, advise them to clean the eyes with wet cotton and it should go away. So reassuring is enough in these cases. The tear duct obstruction, of course, presents by 2 to 3 weeks when the baby starts producing tears. And again, you realize that it is not infection because it's not pus pouring out. You have to teach the parents to be patient because this is something which takes time to clear. I mentioned briefly in the beginning about watery stools in the newborn period. So initially, the baby has meconium, the breastfeeding goes slow, the mother's milk is starting to come. By 5 to 7 days, and in the multigravida, the milk may come sooner. It may happen by 3 to 4 days. So the milk starts coming. We know that the babies have a relatively low lactase enzyme. So it's a physiologic lactose intolerance, we call it, that's normal. And that is one of the reasons probably why nature wants the breast milk to increase gradually. So the long-term health of the baby is better if the breast milk increases more gradually. If you start giving formula, the baby doesn't digest it. If the baby has hypoglycemia and you give formula, for example, you get significant nappy rash because these babies don't digest the lactose very well. And this is a physiologic lactose intolerance. These babies have watery stools once the milk volume increases either from breastfeeding or because you gave unnecessary formula. It's adequate to reassure the parents. You can tell them, guide them not to overfeed, because initially in the hospital, we tell them you need to keep feeding every 2 hours, but we don't tell them that once the milk is coming, once the baby gains weight, you can actually slow down on that. You can allow the baby to sleep longer if they're sleeping in a demand pattern. Many mothers continue to wake up the baby every 2 hours and they get into engorgement, they get into this watery stools and nappy rash and so on. So you don't change the milk in these cases, you reassure them, you give them the feeding advice on how to space the feeds, how to avoid overfeeding, and appropriate feeding. You shouldn't give formula, never change to formula in these babies because it disrupts your breastfeeding, and getting back to exclusive breastfeeding is almost impossible. You don't need to do that. It recovers, but give them the advice on how to feed properly. Again, prolonged or persistent jaundice. Obviously, it's important to rule out conjugated jaundice because if the jaundice continues, you don't assume it's breast milk jaundice. You need to do a direct bilirubin. You may need to do the thyroid function again if the newborn screen was normal even. But there is no role to stop or reduce breastfeedings in the majority. Very rarely you get it approaching the phototherapy level on a repeated basis, in which case you can give 1 or 2 days on formula, but educating the mother to express, but very, very rare. If you see 100 babies with prolonged jaundice or persistent jaundice, it's only 1 or 2 who may need a brief trial on formula, but have a very high threshold for that, educate the parents well. Again, don't take phenobarbital lightly. Even for seizures, phenobarbital is not the first line anymore because it causes apoptosis in certain parts of the brain, including the cerebellum. So there is no role for phenobarbital therapy unless you diagnose a Crigler-Najjar type 2, which is a very rare genetic problem. So for most cases of prolonged jaundice, it's common to see a bilirubin of 13 or 14 at 1 month and sometimes even up to 2 months. As long as the direct bilirubin is normal, the thyroid function is normal, baby is thriving, you may consider ruling out urinary tract infection, but don't stop breastfeeding, because once you stop the breastfeeding, the mother's emotions play a role as well. They may become anxious and they may not want to go back to breastfeeding, or the disruption affects the baby, the confusion, the pattern change, and they may not able to go back to breastfeed. So never take this lightly. Coming on to clinic practice, so it's not uncommon to see antihistamines, cough syrups, nebulization, and I mentioned oral steroids as well for respiratory infections in infants and young children. So we all know that there is no role for these. We know that symptomatic treatment with nasal saline, keeping the room comfortable, hydrating the baby, supporting the feeding should be enough to recover, and monitor the baby for signs that indicate you may have a risk of bacterial infection and so on. But there is pressure to treat. The family has seen other physicians treating their children with these medications. They think if it's a baby, you need to give medicines to treat. And all the more reason you should avoid, because we are having reports from different countries where there are deaths from using cough syrups and so on. And in India, it's banned currently, thankfully, for under 4 years. So such measures are very important to discourage practitioners to avoid medications. Antihistamines have no role because it only dries your secretions. It's a placebo treatment. You give just saline spray and educate the parents. So the 2 or 3 minutes you spend in reassuring them that this is self-resolving, explain the danger signs well, and most of the parents will understand, and tell them that even if you have given this before, you can consider not doing it. And it's often prescribed, and there is also a risk of harm, especially with steroids or with the systemic, the nasal decongestants. It's very important to avoid using them because they can cause rhythm disturbances and so on. Even the nebulized medicines like salbutamol cause tachycardia and agitation in the babies. It's not needed unless you have a clear evidence that it's needed. It's very common to see in UAE, for example, diclofenac is used, and in India, I think mefenamic acid is very common. These are potent non-steroidal anti-inflammatory drugs. They're not really meant to be used for fever. Fever is something that's self-resolving, which you use the basic medications. You can use sponging if needed, make the baby comfortable. Again, the threshold for treating fever, making the parents alarmed when it reaches 39 is not really needed. So educate them that fever is part of the viral infection, and again, using a suppository or injection to treat fever is not necessary as well. So again, proper education becomes important. We need to either prepare leaflets or spend time educating them, or you can employ a nurse who is well versed with these things, who can spend time educating the parents, so you can avoid excessive treatment. In terms of diarrheal illnesses, there should be focus on oral hydration, which is what all the guidelines would say. But unfortunately, it's easier for us to admit and give IV, even if the child is suitable for oral treatment. And again, the type of ORS that's used is important. There are many sports drinks which are marketed as ORS. Very clear documentation is needed because they come in the ORS section of the pharmacy. The pharmacy may get a commission for selling those as well. So make sure you prescribe the right ORS composition for the type of diarrhea the patient has. And recently, Residacotril has been prescribed for almost every diarrhea. It's meant to be used for secretory diarrhea, but again, even for milder diarrhea, and stool thickening agents and so on are not routinely indicated. Motility reducing agents are not routinely indicated. They may be potentially harmful. Seeing dysentery in an older child is not an indication to give antibiotics. You can observe them. If there is high fever or you think there is salmonella infection in the younger kid, you consider antibiotics. But in the older kids, dysentery just needs monitoring and testing the stool so you don't miss amoebiasis and so on. So antibiotic abuse is very common as well. And remember, antibiotic use itself leads to more diarrhea. So you may end up with more trouble because of that. And the people who spoke before me mentioned about the drug resistance and antibiotic overuse. Professor Sukumaran, Dr. Bala, Dr. Riaz, everyone mentioned that antibiotic overuse is a bane. So there is a room for improvement in all fields of medicine. Drug resistance is a huge menace. We don't have many options left. So we should minimize the exposure to antibiotics. And there are many studies coming out that shorter duration of treatments can be adequate. Of course, we have certain infections like group A streptococcus or something where you need a course, but in younger kids. But otherwise, when the child is symptomatically improving, it's reasonable unless it's definite sepsis or meningitis and so on, where you have to follow the regimented, where you are giving for the sake of your doubt, you can stop it earlier. And we need discipline in antibiotic prescription, and we should start focusing on this in the medical schools. It's very difficult to regulate its use in the community. In hospitals, you may have an antibiotic stewardship program where you need to justify whenever you go for a higher spectrum. But for a field like neonatology, for example, where in India, for example, the broad spectrum antibiotic resistance is very common, it becomes almost necessary to use a broad spectrum in a sick child. So how do you restrict the use in those cases? So the answer is over the community-wide reduction, and obviously even in animal husbandry and so on, antibiotic use. So there are so many factors, and I'm not going to discuss all of that. but community education, discipline from all the practitioners, irrespective of what field they are in, and restrict the availability of antibiotics, especially the broader spectrum ones. This is one area where we shouldn't listen to the medical reps at all. There are medical reps who come, I cover cefixime, I cover broad spectrum cephalosporin. Please give at least 1 or 2 per week. So we keep listening to them, and subconsciously you start writing. Remember that broad spectrum cephalosporin should be restricted in their use to the essential patients. Now, even cefepime or the 4th generation cephalosporins are widely used. Never listen to the medical reps' request for antibiotics, because you have a bigger responsibility to the whole community. UTI diagnosis on bag sample, all of us know that it is not going to be reliable. You end up over treating, because sometimes you have colonization with the ESBL as well. The bag sample can be used for routine analysis, but if the routine is abnormal, you always ask for a clean cat sample, or you may do a catheter or a suprapubic if the child is admitted. So never take a bag sample unless it's only for routine. Don't do a culture on that. And RSV positive bronchiolitis often get antibiotics or bronchodilators, which again should be strongly discouraged. I mean, there are guidelines from all bodies on RSV bronchiolitis, but because these are young infants and there is other guideline for young infants which tells you to be aggressive with them, we start worrying about it. Of course, we have the AAP guideline on fever management in babies 21 days and above. Please go through that. It does give you more options to show restraint in such cases. In the NICU, of course, we have a bane of using CPAP or high flow without a blender. So giving 100% oxygen is very, very bad in these babies for the long run. There is a high rate of ROP, and you know that the NNF guidelines covers less than 34 weeks, less than 2 kilo babies, while in the developed world it is less than 32 weeks and less than 1,500 gram. And to do ROP screening for such a big population of babies, so the babies above 1.5 kilo and less than 2 kilo is a huge number in a baby in an area with low birth weight babies. So we have created this problem, and now we will suffer because we have medico-legal implications of not doing ROP screening. How will the ophthalmologist screen so many babies? So that's a problem we have created. Very important to educate your team. If your management doesn't give you the blender, show them the risk of medico-legal liability. There's huge cases where payouts are very high for ROP, and you can convince them by showing them the risk of not doing it. So always use a blender in the labor room. Always use a blender if you're using non-invasive ventilation. If you don't have it, refer the baby out. Don't risk the baby's future because you want to give CPAP without controlling their FiO2. Of course, excessive use of investigations in the NICU comes from lack of confidence, or you may have guidelines which make you do daily tests for a few days or weekly tests and so on. So try to individualize. Same with ventilated babies. Try to wean them quickly to non-invasive modes. Avoid blood gases on a timed basis. Just do it when it is clinically indicated, and the whole team can do the same. And CRP is controversial. Of course, it has a role in ruling out infections, or in a case where you have a strong suspicion to decide on duration of antibiotics. But once the CRP starts trending down, if the culture is negative and baby is well, you don't need to necessarily hold on to a long course of antibiotics, especially if there was meconium stain liquor where the lung inflammation itself could cause a rise in CRP. So we need to be judgmental in using investigations. If you use procalcitonin in the first 3 days, the levels are very high. And it's not due to sepsis, it's because of the metabolism of the procalcitonin or the way it is handled in the body. So obviously don't use procalcitonin in the first 3 days. Avoid excessive reliance on CRP, and tracking it will help you, but to some extent. Don't over-treat because you have a slightly high CRP. Many babies have a CRP of 20 to 30 due after a normal delivery, or a mild like aspiration may provoke it. If they are clinically well, culture is negative, you stop after 48 hours and discharge them. So we have a few issues related to over-treatment. Over-medicalization we discussed. Medico-legal concerns, of course, over-treatment by itself may not cause medico-legal concerns, but the fear of medico-legal concerns makes you over-treat. Excessive protocol-based management, I mentioned in the example of blood gas analysis in NICU. You better off, if you are a senior member of the team, you allow them to decide accordingly. Same with the feed tolerance, feed intolerance, and so on. There may be insurance or payment-related issues, and conflict of interest may come up, or financial implications. If you over-treat, you may make more money. There is pressure from the industry and advertisements related. and pressure from family and peer groups as well. We'll briefly discuss these, but I think, Linz, we have 10 minutes or so, or should we stop sooner?
Sir, I think we are actually short of time.
Okay, so I'll wind up quickly. So patients are more satisfied when they undergo more tests and treatment or they receive more medication. They perceive that something is being done for their benefit, so the physician may end up doing more as well. And there is always a risk, either a treatment or a procedure always has a risk of complications. So doing more may end up in causing more harm as well. And you do get false positive results, and we discussed this earlier as well. And we should be very wary of advertising because there is a lot of focus on emotion, blackmailing to some extent, and we should discourage ads that capitalize on the fear of undiagnosed disease and like master checkups or make them worry about cancer and so on. So we should be rational in the way advertising is targeted. We should be careful about the pharmaceutical industry pressure. I mentioned about the pressure on antibiotics or not the correct ORS formulations, but giving gifts in different ways, sponsoring doctors, attending conferences, symposiums, and so on. So it kind of gets a subliminal effect. So you feel obligated, even if you're practicing ethically, you do feel more favorable towards them, and you may say, why not give it at this situation? So you may be more inclined to prescribe a certain medication or to refer more tests if the clinical justification may not be strong even. So avoid that as far as possible. And if you do participate in events, be careful that it doesn't influence your practice. The most important, start young and focus on training. So we have an approach that encourages the students and trainees to question whether a test, treatment, or procedure is necessary. We need to explore whether they are less invasive and less resource intensive options. They should evaluate whether the patient whether the test is clinically warranted. And of course, we should all aim to be role models. Ethical and non-commercial approach to medicine is important. Each one of us should be role models as far as it comes to ethical practice, the way of pharmaceutical industry influencing us, and keeping ourselves updated and so on. So the way the doctors are remunerated, I mentioned it briefly. If you have a fee-for-service model, you see more patients, you get more benefit, or more tests, more benefit. So this may impact. So you should look at that. And private insurance cover, obviously the patient doesn't pay for it, so you may be more inclined to do this. Encourages defensive practice as well. And there is always a discomfort of uncertainty. So no one is clear about whether they will miss something or not. And the patient and the family should understand that you're making a judgment, but we need close monitoring. I'm not doing this at the moment, but it doesn't mean patient doesn't need it. So educate them, communicate with them in an open fashion. So that will protect you. And if the good rapport is there, you may not end up overdoing. Of course, you have to explain what you're thinking. The next step would be this and so on. And that will help you manage them. The fear of complaints always results in defensive medicine. So the way the complaints are handled in your hospital or in the community is very important. So some doctors recalibrate their practice by carrying out extra tests and procedures, but it's not ideal to do defensive practice. So you need to clearly document, you need to protect yourself. Again, communication, the patient is aware that you are not doing something, but you're expecting to do it. If any worsening, that will protect you if some other doctor says why you didn't do it. And you document what you're speaking as well. So the Google and the family pressure comes in as well. I don't need to mention that because all of you are familiar. And consequences, we already told about the rationing of care, some people missing out, increasing workload of labs and doctors, the other specialties like ROP screening, as I mentioned. The failure to prioritize may mean a poorer outcome to a certain population. And of course, side effects due to the over-treatment may have serious consequences as well. So under-treatment should be corrected by resource allocation, and we need a lot of political will and leadership. Over-treatment needs education at all levels, constant monitoring, remove financial incentives. We need a stronger government regulation on that. Focus on a gentler, more physiologic approach and encourage patients not to come to you if they have minor problems. Remove the fear of medico-legal risk. Educate the society, like either leaflets or meetings for the public in schools. Some of the education is happening through YouTube channels as well. And so you can correct some mindsets of the patients as well as physicians as best as you can. and think carefully about the implications of reclassifying conditions. So we are expanding more, and this causes distrust in the community. We are treating more patients with the lifelong medications, and with the guidelines keep changing. Some days we say coconut oil is bad, some days we say it's good. So the trust in the medical fraternity may reduce. And pharmaceutical industry impact, I mean, this is an example of the cases against Baba Ramdev, for example, for advertising in a wrong way. And close regulation of vaccine updates and evidence-based scrutiny and cost-benefit analysis is important as well. So for example, typhoid vaccine, 1 dose may be enough, and sometimes you continue to give the second dose. So good and honest communication is important, continuity of care and trust in relationship. We should be humble enough to accept limitations when we communicate with parents, with our colleagues as well. And regular education focusing on what really matters. So strengthen the basics, focus on your clinical assessment, educate your juniors in the same way, and make sure that important updates are disseminated. Don't keep information to yourself, share it with everyone, educate the colleagues as well. And of course, if there are some negative impact happening because someone was trying to be holding back on certain treatment because they want to practice ethically, don't blame. Never blame your colleague for their treatment, and support them, so that this will encourage proper practice and discourage defensive practice. So if you are in the medical council or something, the way you approach the complaints is very important, should give you the trust. So last slide, again, go back to the same questions. Do I really need the test or procedure? What are the risks? Are there simpler, safer options? And what happens if I don't do anything? So you may need to ask these questions yourself before you treat something which is not clearly indicated. If it's a clear indication, of course, you're experienced enough to know that you need it. Don't expect the patient to ask you this in the Indian scenario, but ask yourself this question, ask your colleagues the question, spread the knowledge, spread the effort to reduce over-treatment. So to conclude, remember that do no harm and non-maleficence is an important principle. More care doesn't necessarily result in a better outcome, and being aware of that fosters more realistic expectations, a clearer understanding of the patient's condition and prognosis. So if more patients and patients engage in more doctors and patients engage in a honest and open conversation, you would have far-reaching benefits. So follow high ethical principles, always act as a good role model for colleagues and students. So with that, I'll stop. If you have any questions, thank you.
Thank you, sir. Thank you for the excellent presentation. It was actually an eye-opener, this session, especially regarding the use of antibiotics and antipyretics in pediatrics. I think these are the two important groups of drugs which are actually misused. And coming to neonatal part, especially when we are treating TTNB, RDS and all, there are so many units which are actually using antibiotics right and left. So by day 4, day 5, baby might have already received their third line choice also. So it is actually an eye opener, sir. Thank you, sir. Thank you for the session. So any questions or any?
Linz, we have Dr. Jalil Ahmad, our EB, and a neonatologist with more than 30 years of service. Jalil,
Hello,
sir,
sir.
please.
Hello, welcome, sir.
Very good evening, all. Bala, thanks for the opportunity. It is love and nice to see my colleague, Dr. Sridhar Kalyanasudram. He's a very fast-growing YouTuber across the world. And it was a wonderful lecture, Dr. Sridhar. And
Thank
it is
you, Dr.
going to be an eye-opener for many issues, what you have discussed in your presentation. And I'm happy that you have mentioned about the breastfeeding rate across the globe. It is surprised to see you mentioned in the UK it's only 1%. And the rate what you have mentioned, it is for the initiation or the exclusive breastfeeding?
The 4 to 6 months range. I mean, it's not the early stage. In the early stage, we have 20 to 30% in UK, but it's quite bad.
Here in India, the exclusive breastfeeding, the latest IFHS is 63%. But
Yes.
the initiation of breastfeeding, still we are fighting hard. It is around, as you mentioned, it is around 42 to 46%.
Yes.
And excellent. Nice to see you.
Thank
And
you.
this role of that is fever management. We never, after taking the action plan for the past 5 years, we never use, Bala knows well, we never use the NSAID for fever control.
Excellent.
Only we have used the paracetamol, that too in a sick baby IV paracetamol, which you have mentioned already. And you have touched upon all the critical issues in the NICU also. More than that, the ethical factors and all the other issues, what you have discussed, it is a boom for the young neonatologists across the globe. Anyway, very nice to see you, and we'll hope continue this kind of lectures in Tamil Nadu also. Thank you so much. Thank you, Linz, for having Bala. Thank you very much.
Thank you, sir. Thank you for attending.
Myself and Sridhar worked in Ramakrishna Hospital during the DM initial period.
Yes.
And,
It was a great experience.
great.
Thank you, Dr. Jalil.
Thank you so much. Thank you.
Thank you,
And regards to Vidya also.
Sure. Thank you.
We have with us Dr. Santosh, who was our past president. Santosh sir is there?
Santosh sir?
Santosh sir?
Sir, poem.
He is there. He is the person who has started for a DFHI after a long gap of 16 years.
Right.
Actually, Kerala is the only state in the world to be declared VFHI friendly. That was in early 2000. And after almost 17 years, in 2019, when he was the president, we again restarted this MBFHI. But COVID stopped again of almost 2 years. So after that, from 2022, we have started again to revamp BFHI. We started as a MBFHI.
Yeah.
Hopefully, we will increase the early initiation and exclusive breastfeeding rates in the coming years.
Very important. Thank you. Thank you.
Any more points to discuss? Anyone?
And what you said about treatment of many general conditions we are using. For example, for diarrhea, if there is fever, I know many who use antibiotics if diarrhea is associated with fever. Also, UTI, lab error is the most common issue for UTI management, and also for using inhalers, MDI. Now, GINA guidelines slightly they have. Every year they are changing the GINA guidelines, so the use of MDA is also on the increase.
Yes.
So there are a lot of
Overdiagnosing.
Yes, sir.
Yeah. Thank you for your valuable comments.
So, if there is no other points to discuss, we will wind up the session. Thank you, Sridhar sir, for the excellent session for this today. It was actually an enlightening talk. Really an eye-opener. Thank you, sir, for the session. And thank you all who have joined for the session. Suvaran sir, Bala sir, Sumita, Gopi sir, and Riya sir. And thanks
Jalil
to
sir. And Jalil sir.
And everyone who has joined for the session. So we will be continuing with the session. We had actually a gap of 3 months from the last session. So we'll be continuing the session, next session, the next month itself. And hope to see you again soon. Thank you, everyone. We are actually winding up the session.
One small interruption. Sridhar, are you coming to Mahabalipuram for the National Neocon?
Yes, I'm coming.
Which day your topic?
On the first day of the conference, and I'm attending the ventilation workshop in Kanchi Community. Thank you so much. Thank you. Thank you, everyone. It was a nice opportunity to meet all of you, and thank you so much. Good night.
Thank you.